Let's move on to the next topic, which is bullous disorders. First of all, let us see what vesicles and bulla means. Vesicles means fluid-filled lesions which is less than 1 centimeter and bulla is more than 1 centimeter. Let's see the classification. Classification is based on the level of split. One is intraepidermal and another is subepidermal. Intraepidermal includes pemphigus group and subepidermal includes pemphigoid and dermatitis herpetiformis. First of all, let us see intraepidermal pemphigus group. Here, the target protein is desmosomes and the process by which this occurs is acantholysis. Pemphigus vulgaris. It occurs in the age group of 40 to 60 years. Here, the flaccid bulla ruptures and erosion occurs, which tend to extend and has no tendency to heal. Clinical signs. Nilkowski sign. Here, the tangential pressure is applied over the skin, because of which the upper layers of the epidermis separate from the lower layers due to acantholysis. Another sign seen here is bulla spread sign. Here, the pressure over the bulla is applied and irregular angulated margins are seen. In oral mucosa, oral lesions should not be misdiagnosed as Ephthas ulcer because oral pemphigus presents with painful erosions in 90 to 95% of the patients. Investigations here include zinc smear with perinuclear halo. Histopathology shows suprabasal split and acantholytic cells. There is intact stratum basal, row of tombstone appearance. In direct immunofluorescence, which is investigation of choice, autoantibodies are seen. IgG plus C3 is deposited here and it is deposited in intraepidermal intracellular. Here fishnet pattern is seen. Treatment here is high dose systemic steroids, cyclophosphamide. Its side effect is hemorrhagic cystitis and rituximab, which is anti-CD20 used in the management of moderate to severe pemphigus vulgaris. Bullous pemphigoid. It is characterized by immunobullous pathology. Subepidermal antibody is IgG. Here target protein is hemidesmosomes and target antigen is BPAG1 and 2. Here pathology is acantholysis is not present since desmosomes are not involved. Clinical features. It is seen in the 60 to 80 years of age group. This is its morphology, very characteristic. Tense, itchy, bulla on red or normal skin. Signs in bullous disease. Nikolsky sign, here it is negative, and bulla spread sign, here it shows round regular margins. Oral mucosal lesions is seen in 10 to 30% of the patients. Here, in investigation, zinc smear, characteristically eosinophils are seen and no acantholytic cells are seen. This is infiltration of eosinophils and this is epidermal bulla. On direct immunofluorescence, antibody seen here is IgG plus C3, site is basal membrane zone, and pattern is linear. Here treatment is systemic steroids, which is low dose. Next topic is dermatitis herpetiformis. Here autoantibody is IgA. Target is epidermal transglutaminase 3 enzyme. Here level is subepidermal and genetics. It includes HLA-DQ2, DQ8, and B8. Systemic association is with gluten-sensitive enteropathy, which is celiac disease. Clinical features of dermatitis herpetiformis are in morphology, intensely pruritic papillovesicles are seen, grouped excoriations or stretch marks seen, and it is distributed over extensive surface. On investigation, zinc smear, here neutrophils are seen. On histopathology, subepidermal bulla, which is papillary trip microabscess, is seen, which is collection of neutrophils. Here is subepidermal bulla. This is papillary tip microabscess. And on direct immunofluorescence, IgA seen at the basement membrane zone plus dermal papilla and pattern is granular. Here the treatment is gluten-free diet, that is do not consume barley, wheat, oats or rye, and dapsone to inhibit neutrophil chemotaxis. As papillary drip microabscess, that is collection of neutrophils, is present, dapsone can inhibit that. Now let us see difference between pemphigus and bullous pemphigoid. Pathogenesis in pemphigus vulgaris, it is autoimmune skin disorder with IgG antibody against desmoglein. In bullous pemphigoid, it is against hemidesmosomes. Clinical features of pemphigus vulgaris includes flaccid blisters, denuded skin, oromucosal lesions. But in bullous pemphigoid, it is large, dense blisters on flexor surface and trunk. Histology of pemphigus vulgaris includes acantholytic blisters formed in suprabasal layer of epidermis, whereas in pemphigoid it is subepidermal blister with eosinophil-rich infiltrate. Oral mucosa is involved in pemphigus vulgaris and spared in bullous pemphigoid. Nikolsky sign is positive in pemphigus vulgaris, where it is negative in bullous pemphigoid. Now let's see some of the chronic bullous disease of childhood. IgA mediated disorder it is immunobullous pathology, subepidermal and pattern of the skin lesions is cluster of jewels or string of pearl appearance. Annular arrangement of vesicle is seen. Here treatment is dapsone. Mechanobullous diseases are which includes mechanical trauma and bullous lesions. Example, mother on handling baby notices blisters. Term mechanobullous is epidermolysis bullosa. Question here is, when exposed to the friction, a male infant born to a non-consanguineous spouse develops rashes. A kid born to a couple with a similar issue passed away a few days after 1 week of life. What is this condition? It is epidermolysis bullosa. This condition is a rare condition that causes fragile blistering skin. The blisters may appear in response to minor injury, even from heat, rubbing, or scratching. In severe cases, the blisters may occur inside the body, such as lining of the mouth or stomach. This was the previous year question which was asked. Now there are three types of epidermolysis bullosa. One is due to One is simplex, which is due to K5 and K14 defect. One is junctional, which is because of laminin defect, and one is dystrophic, which is due to collagen 7 defect in sublamina densa, which is anchoring fiber. Now some extra questions, previous year questions. What causes the contact dermatitis referred to as scourge of India? That is Parthenium. You can pause the video and read the explanation. Next question, which is fact-based question, which is the following which implicated in the pathogenesis of toxic epidermal necrolysis. It is HLA-B 150. Next question is a 50-year patient has an oral ulcer and skin buildup that are taking time to heal. Where exactly is the lesion? It is suprabasal. Thank you.